Thank you so much for joining us today. And would you please put your name into chat and your facility and your position and who else might be on the call or in the meeting with you? Anyway, welcome to everyone for attending our first of the 4-part series, Sepsis, Working Together to Prevent Sepsis. The series is brought to you by the long-term care, post-acute care team at Comagin Health. And we have 6 states in our region. They are Idaho, Nevada, New Mexico, Oregon, Utah, and Washington. So welcome to everybody from our region. My name's Connie Lauder, and I'm an improvement advisor for the Long-Term Care Project. And I'm also the facilitator for today's learning session. This session is being recorded for on-demand viewing later for those who can't join us today, or if you want to just do a refresher of the information that we shared, or if you want to share it with other people in your facility later. Before we begin, I'd like to encourage you to put yourself on camera so we can see each other, and to take yourself off mute and be part of the discussion when it's appropriate. If your computer doesn't have a microphone, dial in and follow the prompts to the link on your phone. Dial in and follow the prompts to link your phone to your computer. This information is being dropped into chat by Brita today. Next slide, please. We know your time is valuable and your schedules are extremely busy. So these sessions are scheduled for 30 minutes. To help with this new time format, the learning portion of these sessions will be 25 minutes, with the end for questions and answers. The team will stay on the call and in the Zoom room afterwards in case there are additional questions that didn't get answered, or if you want to ask one after the session is done. Next slide, please. Today is the first week of the learning series, Working Together to Prevent Sepsis. And we'll be meeting at the same time for the next 4 weeks. We have 0.5 nursing CEUs available after attending each session. You'll need to attend all 30 minutes and complete the evaluation after the sessions to receive the CEUs. Week 1 is a refresher of what sepsis is and how to recognize an early onset. Now, we realize that most of you that are attending today are clinical and have most likely had some sort of experience with sepsis during your career. But we feel it's important to take this time to inform you of some new information about sepsis or to remind you of what to watch for as you assess your residents. And no matter who works in your facility or what their job titles and duties may be, all of your staff will see the residents at some time. They should share their observations with nursing staff. It can help the nurses detect early changes that indicate the beginning of sepsis. And this recognition is vital in starting treatment early enough to allow your residents to stay in your facility and to avoid a transfer to the hospital. Your presenter today is Charity O'Neill. She's a nurse improvement advisor here at Comagin Health. And take it away, Charity.
So hello, everyone. My name is Charity O'Neill. I'm an improvement advisor with Comagin Health. A little about me and my background. I have been a nurse for 18 years, and I have worked from short-term to long-term care and everything in between. I have been with Comagin Health for a little over 9 years. So thanks for being here today. Let's get started and dive deep into sepsis. I once read the saying about sepsis, and it stuck with me. Trying to understand sepsis is like trying to smell the color 9. Sepsis is a complicated condition that needs more recognition to be able to identify and understand. Next slide, please. So from this session today, you should be able to define sepsis and its different forms, understand the pathophysiology of sepsis, and understand the urgency to recognize sepsis early. Next slide, please. So sepsis is caused when the body's immune system becomes overreactive in response to an infection, causing inflammation, which can affect how well other tissues and organs work. When sepsis is recognized early, people can be quickly given the right treatment. However, the signs and symptoms of sepsis can vary and may be subtle, which can lead to it being missed if it's not considered early on. Next slide, please. So, what is sepsis and why does it matter? This slide shows some insane statistics and how dangerous sepsis is. As clinicians, we probably all have some knowledge base or understanding of sepsis. So you may be asking what makes this session or series different from other educational series in sepsis. Well, we at CoImagine Health have a team of rock stars that bring a variety of expertise to the table. We want to help you and your facilities be successful in recognizing, treating, and ultimately decreasing sepsis. As we start this series, this is just a reminder of basic information to reconnect to sepsis. We know that there is education out there on sepsis, but sepsis is ever changing, making it vital to reconnect and remind ourselves of what sepsis is. Next slide, please. So multiple celebrities have died from sepsis, including Christopher Reeve, who portrayed Superman, Jim Henson, who passed away from sepsis from pneumonia, and Muhammad Ali, he also died from sepsis. So it doesn't matter if you are famous or not, sepsis is a condition that anyone can get. Sepsis is a serious condition in which the body responds improperly to an infection. The infection-fighting processes turn on the body, causing the organs to work poorly. Anyone can get an infection, so anyone can be affected by sepsis. And when we're looking at these infections, it could be, COVID-19, your infected wounds, UTI. Sepsis is very dangerous, and if not treated timely, it can ultimately lead to death. Next slide, please. So the pathophysiology of sepsis. The fundamental concept to keep in mind when discussing sepsis is that of hemostasis, the healthy balance of blood coagulation versus anticoagulation. In times of normal health, our bodies produce clotting factors in the blood that are always on standby to clot whenever necessary. These factors are activated whenever the endothelium, that's the lining of the organs and blood vessels, is disturbed or traumatized. Clotting factors are like a reserve of highly unstable gunpowder. Once activated, they can set off a dangerous chain reaction of clotting everywhere. This potential is kept in check by anticoagulating factors also present in healthy blood. So in sepsis, infecting organisms can cause direct trauma to the endothelium, and the body also suppresses or depletes the supply of available anticoagulating factors. It's a perfect storm of intravascular coagulation that occurs everywhere in the body, most notably in the most delicate microvascular system. This leads to hypoperfusion and clinical exam findings of end organ injury. The endothelium continues to malfunction, resulting in loss of blood vessel wall motor tone, which leads to hypotension, as well as leaky blood vessels, which leads to edema in the lungs, brain, and soft tissues. Next slide, please. So this is the sepsis spectrum. So SIRS, the systemic inflammatory response, this is where abnormal vital signs are appearing and blood work is out of the normal parameters. As time passes and the resident's condition is changing, the spectrum now moves to sepsis, where the resident presents with SIRS symptoms and apparent infection. Residents are diagnosed with sepsis when they develop a set of signs and symptoms related to sepsis. Sepsis is not diagnosed based on an infection itself. If you have more than one of the symptoms of SIRS, especially if there are signs of an infection or you fall into one of the higher risk groups, it should trigger to suspect sepsis. So progression from here is to severe sepsis, when your resident is showing more abnormalities and declining rapidly. If you can see hypotension, organs failing, along with even more abnormal lab work. Then septic shock hits, severe sepsis, organ dysfunction, and the mortality rate is at 50% at this level. The risk of dying from sepsis increases by as much as 8% for every hour treatment is delayed. The farther you progress on the spectrum, the higher the mortality rate. Next slide, please. SIRS is a constellation of associated abnormal vital signs that are not specific for any one disease. 60% of all emergency department residents happen to meet SIRS criteria, but they don't all have an infection. As a good rule of thumb, if your patient resident meets SIRS criteria for any reason, they are probably critically ill. Next slide, please. So in your residence, you're going to watch for changes with all vital organs. And I'm going to give you some examples of these. So for your respiratory, you're going to look for your oxygen saturation. Is it dropping? Increased need of oxygen. So example, Miss Jones had to bump her oxygen up from 2 liters to 3 liters in order to keep her sats greater than 90%. You're going to watch for cardiac changes. You know, Miss Jones' BP dropped this morning. Her baseline is usually around 120s over 80, and today she's at 83 over 62. Take note of renal changes. You know, Miss Jones has a catheter. Her normal output for today has decreased by 400 mils. This is not at her baseline. We're going to look at temperature. Miss Jones' temp dropped. Her baseline is around 98.3 range, and today 97.4. Your central nervous system, signs and symptoms. So Miss Jones was more confused today. She didn't know who I was, and I'm her routine nurse. Or you may have the scenario of Miss Jones is very lethargic today. Normally she is up and ready to go to bingo. She never misses. So a quick tool for your staff is the acronym TIME. This is like a quick assessment for your staff to trigger like for sepsis. So T is for temp. Is it higher or lower than normal? I is infection. Is there any signs and symptoms of infection in your resident? M is for mental decline. So are we seeing confusion, more sleepiness, difficult to rouse? And the E is extremely ill. So you may see your residents make a comment like, I feel like I might die, or I'm in severe pain or discomfort. And Whitney just dropped into chat a sepsis fact sheet for you guys to review on your own time. Next slide. So I just want to take a time for just a moment of reflection. And so far, does any of this resonate with any of you guys in your facility? Another question is, can you identify some Miss Joneses in your facility? And what does your process or the outcome of any kind of resident you've had with sepsis recently? So I'm going to open it up to see if anybody wants to share an experience that they've had with a sepsis patient. We love interaction. Don't be shy. Okay, we'll continue on. Next slide, please. Okay. So some people are at higher risk of developing sepsis because they are at higher risk of contracting an infection. These include the very young, our elderly, and those with chronic illnesses, and those with a weakened or impaired immune system. People who are malnourished can also contract infections more easily. Next slide, please. All right, so in the long-term care setting, I'm sure you can recognize several of the at-risk residents on the screen that are common to residents in your facility. You know, like we've seen catheters, wheelchair-bound residents, your post-op joint replacements. So one that stands out to me is your diabetics. Your residents are extreme risk due to the severity of the disease. Your neuropathy, prone to wounds, poor circulation, dialysis, those are all on top of just being diabetic. And so one statistic I read in regards to this is every day in the US, an average of 38 amputations are required because of sepsis. So it just shows how chronic and severe diabetes is. Next slide, please. Okay, looking for any changes in condition is the way to identify your sepsis resident. So your CNAs, your nurses, being familiar with each resident's baseline. Staff need to be on alert, performing in-depth head-to-toe assessments. Encourage your CNAs to report changes. Even if they feel like it's not a big deal, it may be an early catch to identifying the start of an infection. We want to be able to identify the signs and symptoms early to prevent further progression of sepsis. Next slide, please. So early recognition. I'm going to give you a few examples. So your example, Miss Jones goes to bingo faithfully every Monday. Monday comes and bingo starts. Miss Jones wasn't there. CNA reports that Miss Jones said she was too tired to go. Subtle change. Is Miss Jones getting sick? Or does this alert your nurse to do further assessment? What does your process look like? Is priority charting triggered? Knowing the residents and their baseline is vital, especially in regards to monitoring and trending vital signs. Our bodies will begin to send signals when it's under attack. Is the finding outside of the resident's baseline? All voices should be welcomed. Encourage family, your dietary maintenance guy to report any changes if they identify them. I was working in a SNF who used the Interact tool Stop and Watch. This facility encouraged everyone to fill out if they had noticed a change. It was encouraged and well known that no stop and watch was invalid and that the nurse had to follow up on the change reported. The maintenance employee filled out one on a resident that he had been in his room doing maintenance on. And he noticed that the resident just seemed different each day he was in there. He filled out a stop and watch, gave it to the nurse, and come to find out the patient had a UTI. It was caught early and treated. This prevented severe decline in the resident, possible sepsis, and a hospital transfer. Encouraging everyone to have a voice helps identify changes. Next slide, please. So the urgency of early recognition. Collaboration and communication between team members is vital to early recognition. Being proactive, catching early versus reactive when the resident is already severely ill is going to help with resident outcomes. Encourage staff to be advocates for your residents. Early identification and application of treatment can immensely improve resident outcomes. Next slide, please. So I appreciate your time and attention. Take time this next week to evaluate your facility. What does sepsis look like in your facility? Are your rates high? Do you have a process in place for identifying and communicating changes in condition? We want to see you next week, and we have tools and resources that can help your facility. So next session, which is session 2, we'll dive deeper into the recognition and treatment of sepsis, and sepsis tools will be introduced as well. So I will now pass it back to Connie to close out this session.
Thank you so much, Charity. That was really important information and appreciate you sharing it. This slide has some resources that were used in today's presentation. The Sepsis Alliance is an excellent resource. It is for professionals and for the public, and I highly, highly recommend it. They also have webinars and educational opportunities for staff and nurses. Some of them have CEUs, but I just really recommend that you register to access their site. It is free. There is no charge, but they do ask that you register, similar to what the IHI, the Institute for Healthcare Improvement, does. Next slide, please. This is a list of the state leads for all of the regions in Idaho. I mean, I'm from Idaho. This is all the state leads for the regions in COMAGIN. If you have any questions or comments or suggestions, reach out to your lead for your state. Their contact information is here. Next slide, please. We have 3 projects that are going on that we really encourage people to consider participating in. The first one is medication safety, which is led by Megan Moore and Charity O'Neill. And this one focuses on reducing adverse drug events. Next slide, please. Oh, I'm sorry, go back. My bad. The next project is care coordination, and it is led by Rita Ugandu Igwe and Whitney O'Donnell. This project's focus is decreasing the number of rehospitalizations and visits to the emergency department. Then there's the Take Down 5 campaign, which is led by myself, Connie Lauder, and Lisa Barton. This project focuses on helping nursing homes reduce their rates in 5 conditions, which are UTIs, pneumonia, COVID-19, C. diff, and sepsis. If any of these 3 projects are something that you may be interested in, go ahead and contact the lead for the projects. Talk to your QAPI committee, talk to your staff development coordinator, talk to your staff. What is it that they would like to learn more about? And what do you feel your facility could benefit by participating? Next slide, please. And again, as a reminder, following each session, you will receive an email that includes this link, which you will need to complete to get your CEUs. You will need to complete this to get your 0.5 CEUs every session. Next slide, please. And now I'm opening it up for any questions or concerns about sepsis that you may have for your facility. Everybody here have sepsis at one time or another, right?
Looks
Okay,
like
I have a
Christina said
question.
yes in the chat.
Oh, cool.
Christina, do you have any experiences you'd like to share? Particularly looking at, residents that were either diagnosed with sepsis or maybe potentially, even that had some of the symptoms for SIRS, like we talked about.
Yeah, we see occasionally that's resident with sepsis typically is UTI, catheter-associated UTIs that progress to sepsis, dehydration, That's what we see, maybe twice a year, something like that. But it could be related to the clientele we work with too. We have residents that have dementia, and so it is kind of they will not ask for frequent hydration, things like that. So we have to be on top of that they are getting the hydration they need and to manage better that,
Well, and I know moving into like the sessions coming up, but to speak to that right now, we even in the facility I worked with here, so I'm in Nevada, they had a lot of the catheter associated sepsis. And so again, going back to catching it very early, you can start to treat those symptoms, push fluids, like to prevent the complications in the long run. So I know next session, Whitney is actually going to be presenting, and she has tons of tools to bring back to your facilities to help with this.
Yeah, and you're right, Christina. The clientele in nursing homes, a lot of times they'll have dementia, and it makes it very difficult. I know my mom was in a nursing home and she had a catheter for the first day or two that she was in the home. It was after a hip surgery. And well, she DC'd that catheter on her own. by she got confused one night and it was bothering her and she pulled it out, caused trauma to the urethra, and she ended up with a really bad case of UTI, and it never really cleared. It just kept coming back and coming back and coming back. So she eventually got sepsis from it.
Hi, can anybody hear me? Awesome. All right. Sorry, something crossed my mind when Christina was saying something. I just wanted to check with you guys because normally when you are able to, I don't know if you have a process of looking at your readmissions to learn what was diagnosed in the hospital, like each of them coming back, you know, what was diagnosed, because sometimes we might be looking at suspecting a certain diagnosis, treating, and then when they go to the hospital, UTI, pneumonia, that we weren't even suspecting, or sepsis. So that way, it helps you to understand the number of your residents that are coming back from hospital with sepsis diagnosis. And then that can kind of help you to dive into detail, the root cause, and see where you missed things, and now have a plan on how to prevent such in future. I'm trying to say that if you don't have a process that kind of review each of those transfers and, you know, rehospitalization to learn the contributing factors or know if it came back with diagnosis of sepsis, you might not keep track of number of sepsis that is going on, or, you know, pay attention to it. So do you guys have a process that help you look at each of your readmissions?
Well, we don't have that many discharge to hospital as re-entries, you know. Typically, when we send people out, is because, you know, change of vital signs unstable or change of medication accompanied with vital sign change. And then we find out after they've been admitted that they had sepsis, you know.
Yeah.
But yeah, we do track how they come back and what's the diagnosis, you know, but it's not, I mean, the incident we have is very low in our facility.
So is there any practice associated to you having a low sepsis, you know, rate? Is it that you have a process of kind of assessing residents that are high risk, mitigate it? I mean, what is behind that success? Because some people really have struggled with that, and it seems that you guys have control over it. What's the secret? The magic you're doing?
What's your magic sauce?
Yeah. It's just a miracle happening for you guys, something like that. Like, lucky.
Maybe it's related that we do, the clientele we have, they are very dependent, and we control all the intakes and outputs, and we monitor every shift, all that, you know. So, and I think it has to do with that. The people that we had, like the last year, that went to the hospital and got that diagnosis, unfortunately, they were all catheter associated, and it was long-term use of catheter. So people that cannot be discontinued with the catheter, you know.
Okay, all right.
Yeah.
Good. Thanks for sharing.
Yeah.
We have someone on the call that says staff developer. Unfortunately, I don't know your name. I'm sorry. But I'm curious because I know your role is to provide and dish education to your team. I just wanted to, out of curiosity, do you guys have a process in place that help you? Like, what have you done with education around sepsis for your team? Are you guys, do you have any kind of training on that? Are you there?
Yes. I mean, it's
Yeah,
still
there's
expected
someone
staff.
that says staff developer, and I know that is staff education coordinator, that role. I just wanted to learn their process so far, if they have any education targeting staff, skills, how to identify sepsis and all that. Just to know what kind of, or generally, what kind of training are you doing around sepsis, or have you any process to help identify sepsis in place?
So we do have the staff developer program. Unfortunately, it gets staffing issues, it gets, it doesn't get to be done frequently. And we implemented, so we did a QAPI training, a QAPI meeting to see how to improve that, prevent, to manage UTIs, and increase frequency of changing the reusable bags, for the leg bags, that we do dispose, we do not reuse, and it's a kind of high cost for the facility, but it prevents, the contamination in that part, because you are using new bags every day. And since we encourage, we put a fluid enhancement programs that the Maydays are actually the ones doing that instead of the CNAs, and having, so that way we have a track the amount they're taking and every shift, and doesn't need to be changed or not, or things like that,
Yeah.
So that's what we do.
Well, thank you, Christina. Those are
Sure.
great practices. I noticed some people have taken themselves off mute and off camera, back onto camera, but I also need to let everybody know that we've reached the 30-minute mark. We thank you for joining us. We will be staying and continue this conversation, but if you need to leave, feel free to leave. Thank you, Donna. Carlene.
Hi.
I noticed you took yourself off camera. I mean, put
That's-
yourself back on camera. Did you want to add
That's
anything?
true. That actually, I'm waving goodbye and thank you for a great seminar.
Oh, well, thank you. And I love your background, by the way.
Thanks.
Wanda, I noticed you took yourself off mute. Did you want to add anything to the conversation? Okay.
I think Wanda might be either on the phone potentially.
Oh,
I'm
yeah.
not sure they have a microphone associated with that login.
Okay.
But Wanda, if you have something, oh, okay, awesome. I thought that might have been you on the phone. Feel free if you have something to chime in, or if you have questions, feel free to either take yourself off mute on that phone. Or I know sometimes it can get tricky with the phone too. Feel free to put stuff in chat as well.
Okay. Well, I hope that you all found something interesting in this. One thing I wanted to point out is make sure you look at your labs on your residents and look for little subtle changes. Been fighting my husband's infections, and his platelets were dropping like a stone. But the lactic acid was always okay. And then when his lactic acid started to rise, he was really sick. So look for subtle changes. The dropping platelets is something that somebody should have caught. So those little changes can be the difference between life and death in some septic patients and residents. Anything else that people would like to add? Well, we thank you so much for joining us today, and we will see you next week when Whitney shares all of the tools that she has and the treatment plans and the protocols. So we will see you next week. Thank you so much for joining us. Bye-bye.